joining us on this Friday morning. My name is Brianna Gonsalves, and I'm with CTAC and MICTAC, and I'd like to welcome you to today's webinar, 2021 Changes to Coding and Documentation of Evaluation and Management Codes for Article 31 Clinics. So before we get started, before I pass it along to Seth and Rachel, I want to make sure that everyone knows how best to participate in today's event. So just so you know, upon joining, you have been placed on mute to avoid any background noises that may distract others from listening to today's presentation. So the best way to communicate with us is by using that chat box feature. It may appear on the right-hand side of your screen, but if you don't see it right now, you can look to the bottom right. There's a dialog bubble that says chat right next to it. Just click that and the chat box will appear. And if you run into any technical issues, audio, visuals, please send a chat using that chat box again to CTAC admin, and she will be able to assist you. Also, in order to ensure that we're able to answer as many questions as possible at the end of today's presentation, we're asking that everyone submit their questions throughout the presentation. So the Q&A portion will take place at the very end, and we'll be collecting those questions throughout. So just make sure when you are submitting questions to please chat to all panelists. There's a drop down of the chat box where it says send to, and you can select the panelist option there. And so everyone knows today's webinar is being recorded, and so we'll have that up on the CTAC NY website in 2 to 3 business days. And lastly, there will be a feedback survey at the end of today's presentation. So if you have a minute to fill that out, please go ahead and do so. We'd love to hear your thoughts. So thank you again, everyone, for joining us. I'll now turn it over to Rachel and Seth to get us started.
Okay, welcome everyone. We're going to proceed now with an outline of what I think is a very significant and substantial change that AMA through the CPT committee has implemented for both documentation and code selection for the evaluation and management codes starting in January 1st of this year, and a concomitant increase by the Medicare program in the RVU values that are assigned to the evaluation and management codes. So we have two things going on at the same time that are very beneficial to psychiatrists working in clinics and in private practice for that matter, is that simultaneously we have a significant increase in the RVU value assigned to those codes, 213 and 214. We're going to be focusing on 99213 and 99214. And simultaneously, we have substantial reduction in the documentation burden that was placed, that had been imposed previously for those codes. So we have two positive directions: increased reimbursement, simplified documentation. And that's what we're going to explain to you today, how to turn that around and implement that in a manner that will, in our perception, significantly enhance reimbursement for those services from Medicare and other third-party payers. So I'm going to turn it over now to Rachel, who will start the presentation. I'm going to jump in when I think something needs to be emphasized or reinforced in terms of operational criteria and how to implement these from a practical consideration. So I'll stop there and actually mute myself. And
Okay, good morning, everyone. Just for a little bit of an overview, these new documentation rules went into effect on January 1 of 2021. So they've been in effect almost 3 months now. It's very important to note that these changes in coding and documentation apply only to evaluation and management codes for office and other outpatient services. They do not apply to all the other E&M codes, which are inpatient, nursing home, etc. So these are really just the office and outpatient. AMA and CPT have indicated that they do expect in the future to bring these changes to all E&M codes, but we'll see whether that happens the next year or a couple of years. So today the training is focused entirely on 99202 through 99205, that's for a new patient. And with respect to an established patient, 99211 through 99215. Okay, so the most significant change is that we now have two options for selecting the appropriate E&M code for the service being rendered. And they're really, two different silos and ways to think about selecting the appropriate code. The first one is the level of medical decision-making that is involved with the service being provided. And, there's some new criteria for looking at medical decision-making. The other option is total time. And that is a new concept. It combines both face-to-face time and other time spent providing a service on the same day that the patient was in the clinic. And I will show you exactly what that means. So really, when you're billing an E&M code, the practitioner can, really has an option to use medical decision-making as the documentation basis or time. Okay, and we're going to go through each one separately, and you'll see how some may be more appropriate in different situations. And also, of course, we understand that you have, also requirements with respect to OMH that may also come into play in terms of the decision-making process. Okay, so just to give everyone a framework, we're not going to focus today on the combination psychotherapy claims. We understand that those claims are not frequently used in the context of an Article 31 clinic, but we just mentioned that when you are using an E&M plus psychotherapy add-on, and those add-ons are 90833, 90836, or 90838, depending on the total face-to-face time, the E&M would be selected only based on MDM. So we'll just mention that. I'm not going to go on that further, but that's one aspect of this. Now, we're focusing today mostly on the standalone E&M claims. So again, it's either medical decision-making or time. Okay, now this is a big change. So previously, in order to document, for example, an established patient E&M service in an office or outpatient, you needed to document 2 out of 3 key components. Those components were history, exam, and medical decision-making. So now the inquiry is the minimum inquiry is focused on medical decision-making. History and exam are of course still a component of the service and the documentation of the service, but they are not the basis for code selection. So you're still going to document interval history as medically appropriate, and you're going to perform the mental status exam as clinically appropriate. But you're no longer going to be, counting the elements to make sure that you reach the minimum number of elements. So again, it's just a focus on clinical relevance on the date of the service. Okay, so now I want to jump into medical decision-making. And the first, just to remind everyone that like many elements of the CPT, in the CPT book, medical decision-making also has 3 elements. And in order to properly document a code, you must document 2 out of 3 of these elements. So we have the number and complexity of problems addressed during the encounter. We have the amount or complexity of data to be reviewed and analyzed. And then 3, we have risk. The risk of any complications or morbidity and or mortality with respect to the patient management decisions that the practitioner makes at the visit. So we said you need 2 out of 3. So today we're going to focus on 1 and 3 because you don't always have data to review. So we're going to leave that one out for the time being. Of course, if you do have data to review with respect to a particular patient, then you might add that in as well. But again, in terms of qualifying for a certain E&M code based on medical decision-making, 1 and 3 are always the key factors to look at. Okay, so this is a chart we put together. It is sort of an excerpt of a larger, more complicated chart that is in the CPT book. This really focuses on on MDM from a perspective of psychiatric care and treatment. So what we have is we have down the left-hand side, we have each of the CPT codes. the level 2, level 3, level 4, level 5. And as you can see, each one corresponds to a level of medical decision making. So the two that I think will come up most frequently are the level 3, low medical decision making, and level 4, moderate medical decision making. And we're going to go through all these definitions, but there's some new key terms here. So in the level 3 row, you can see that when we are under element 1, which is the presenting problems, what is the patient being treated for? In order to qualify for level 3, you need to be treating one stable chronic illness. And there is a very interesting definition of that term, but it's really, many mental illnesses are lifelong chronic illnesses. So that's what we're talking about. Now, there's another option for presenting problems for level 3. It's an acute uncomplicated illness. And we'll talk about what the definition of that is. Now, so we're skipping element 2, right? Because we said we most often do not have data to look at. In element 3, in the final column, how do you demonstrate low risk? And the way you demonstrate low risk is continued treatment. This is an ongoing psychiatric treatment. So level 3, almost all patients will qualify for level 3 in many cases. Now, let's jump to level 4, which is, as you can see, the acuity increases and the presenting problems increase significantly. So level 4 is moderate decision making. Now, in order to meet the presenting problems element, you need to either have one of two options: 2 or more stable chronic illnesses, and they're both the focus of psychiatric treatment. Or the other option is if you're treating the patient for only one or more, but you only need minimum of one, a chronic illness, but that illness has exhibited exacerbation, progression, or side effects. So we're talking about a patient presenting with a more acute situation. Now, let's jump to the final column, element 3. Remember, you need 2 out of 3 key elements. So how do you demonstrate moderate risk of the management decisions? One of the most straightforward ways is if you're treating the patient with prescription drug management. And another option that is appropriate for psychiatry would be if the patient's diagnosis or their treatment is significantly limited by social determinants of health. That's another example. That might be someone who has food insecurity or housing insecurity.
However, I just want to intrude. This is the key to the entire presentation, is that we estimate that a significant portion of the patients seen by psychiatrists for medication management would thereby qualify for a level 4 because they're on medication and they either have 2 or more stable chronic illnesses, which are the focus of treatment by the psychiatrist, or they have one chronic illness which is not stable. We'll talk about not being stable very shortly. So I want to emphasize that's really the nub of this presentation, right? Just right there is that historically we know that psychiatrists doing their 15-minute medication visit under OMH regulations, and that's we're not billing typically for a level 4, and because the requirements previously for documentation of a level 4 were problematic, and there's a perception of the time that was associated with them that was greater than 15 minutes. And for those, but now those have changed. And this is the requirement for a level 4. And with MDM, there's no minimum time requirement. There is an OMH minimum time requirement of 15 minutes, but that works perfectly fine with a level 4 for CPT purposes. So I'll just put a punctuation mark or exclamation point on that.
Okay, thank you, Seth. And I'll just, quickly review the level 5, which, may come up from time to time, but it's, a chronic illness with severe exacerbation or something that poses a threat to life or bodily function. This would often be when you're considering hospital level care for the patient.
The other example here is when you're doing, when they're being treated with drug therapy that requires intensive monitoring for toxicity. That's another example, but you still need the presenting problem that has severe exacerbation. So as day to day, we're really, I think, focused on level 3 and level 4 as the most common. Okay, so now we wanted to show you some of the definitions of the terms that we were just talking about. So the first one is the stable chronic illness. So this is, the hallmark of level 3. It's a problem with an expected duration of at least 1 year or until the death of the patient. So this is a chronic illness. And with respect to chronicity, a condition is treated as chronic, whether or not the stage of the illness or the severity changes. For example, uncontrolled diabetes and controlled diabetes are a single chronic condition. And obviously patients wax and wane. Now, stable, the way they think about stable is looking at the specific treatment goals for a specific patient. Now, and the orange quote here, stable, is right from the CPT book. A patient that is not at their treatment goal is not stable, even if the condition has not changed and there's no short-term threat to life or function. So I think, what we need to think about is a patient is still working towards treatment goals, still improving functioning, still working on reducing their symptoms, then they would not be in the stable chronic illness category. They would most likely, and it depends on the patient, but they would most likely jump up to the moderate level of decision making where you have a chronic illness with some form of exacerbation. Okay, here's an example that the APA had put out, and they were, generous enough to share these with us and allow them to share them with you. So a 50-year-old, a longstanding diagnosis of bipolar disorder, stable on a continuing regimen, following up every 6 months. So that's an example of a stable chronic illness. Now let's jump to, this is just another example for 99213, the acute uncomplicated illness or injury. So this is a short-term problem, little to no risk of mortality, full recovery is expected. So the example that the APA has suggested here is a young individual who, who had a relationship issue, who's very depressed, and a neurovegetative symptoms, but we know that will clear up.
Symptoms, normal neurovegetative symptoms, right?
Normal, right, normal.
The person isn't, not eating and not sleeping altogether, right?
Right, someone who's depressed, or unhappy because of a relationship issue and is, So that's, this also would qualify for 99213, a low medical decision-making with continued treatment. Okay, so now this is the language for 99214, the chronic illness with exacerbation, progression, or side effects. So this is something that is acutely worsening, is poorly controlled or progressing while the provider is, intending to control progression, and that requires additional care, but does not lend it, does not require consideration of hospital level care. That's where we get into the level 5. Again, I've repeated the definition of stable here to indicate that if someone is not at their treatment goal, they're still experiencing symptoms or side effects, then they're not stable and they would most likely qualify for the level 4, exacerbation. Okay, so the example here is another individual with bipolar disorder who has persistent mood symptoms. That's the difference between stable, not stable. Okay, now this is the level 5 language. So we have severe exacerbation, again, may require hospital level of care, someone who's really, worsening and needs a higher level of treatment.
So our sense is here that this is a rare occurrence, but in an Article 31 clinic, it may occur where a patient comes in who's being seen, let's say once a month or less frequently perhaps, and has seriously deteriorated, and you're contemplating calling 911 to have them taken to the nearest receiving hospital, then and they were there for a medication visit, that would be a level 5. Heretofore, without these changes, that would presumably be impossible based upon the criteria for selecting that level 5. But now, because of the change based on the patient's condition rather than arbitrary elements of documentation, this even could be available, but it would be, you know, obviously unusual, but available, but unusual. All right.
Okay, so just to clarify that when you're selecting the CPT code based on medical decision making, you're looking at these elements. You're looking at the elements of medical decision making, and aside from the minimum time that is required under the OMH guidelines that for you to spend with the patient face to face, the code selection is determined by the elements of medical decision making. The time alone does not determine the code selection. And we're going to switch gears in a minute or two to look at when time is the sole basis for selecting code. But in this case, it's MDM alone, and you're focusing on the elements as we've discussed, presenting problems and risk, and perhaps data if that's appropriate. Okay, so I'm going to, Seth, if you don't have anything else to add at this moment, I'm going to switch into time. Okay, so this is the other sort of silo, another way to think about code selection and documentation. Okay, so what AMA did this year is that they added a new concept called total time, and that includes all E&M services provided on the date of the patient encounter. So it includes the face-to-face time, you know, when the patient is in the office with you during the encounter, plus other non-face-to-face time that the physician or other qualified healthcare professional, you know, not an admin person, but you know, another clinician is performing on that day, the same day the patient comes into the clinic. So what are these other services that might count? These are a list of the activities that count towards total time. And this is, you know, this is the list from the CPT book. You know, nothing else should be included. But for example, preparing to see the patient, you know, review of tests that have come in, or reviewing history that has been obtained, speaking to other individuals regarding the patient's care, prior authorization, time spent on the phone doing a prior authorization for medication, referrals, also documenting clinical information in the record. So if you're preparing the record, the health record, after the patient has left, that also can be included, you know, depending on how what your clinic's rules are and whether that comports with OMH guidelines, care coordination. So these are all the things that you might do on the same day that the patient comes in, and that can be included in the total time. So an example might be if a patient is in for 15 minutes, but an additional 15 minutes is performed, you know, doing a prior authorization on the phone, that would be a 30 minutes total time. So it just shows you the different aspects here, the power of some of these changes to account for all the activities that go on in connection with a patient encounter. So another change here, this is for the new patient codes. So we always had the E&Ms for office and outpatient, always had a typical time. And that was, you know, you weren't held to it. It wasn't a minimum or maximum. It was just a typical time, a generic framework. So now we've gotten rid of that and we moved towards specific time frames. So as you can see, the 99203 is now 30 to 44 minutes. That's it. When you're billing on time, when you're using time as your basis for code selection, if you fall into that window, it's a 99203. And this is for new patients coming in. So again, the 99204 is between 45 and 59 minutes. Again, the 99205 is 60 minutes or higher. So it just makes it a little simpler, and that's the way they've done it. Now, this is the established patient codes. So really the 99213 is 20 minutes minimum. The 99214 is 30 minutes minimum. And again, the 5 is 40. So
However,
yes,
these minima only apply if you're selecting the code based on time. If you're selecting it on minimum medical decision making, these times are irrelevant. So that if you have a chronic patient with 2 chronic illnesses on medication, that is a 99214, regardless of the duration of the visit. So we only put this in for two reasons. One is to let you know what it is, but to demonstrate the power of the change, because otherwise, heretofore, that 99214 was not easily available. But now it could be a code that's used 90% of the time because you meet the criteria under MDM, and there is no time factor when you have MDM other than what's clinically appropriate under the circumstances. And in our lecturing, we agree with OMH that for a medication visit, 15 minutes is an appropriate duration for that particular service. That's what we lecture on, at 15 minutes for that medication visit. So, but if you were doing it on time, then 15 minutes wouldn't work for a 99214. It would have to be 30 minutes. But it's not 30 minutes if you pick that code based on medical decision making. And that's the power of what this change has done. And I just want to make sure that everybody understands that this is not for psychiatry per se. This is for all medical specialties, internists, cardiologists, everyone. These are the new rules when you go to the doctor yourself, and this is the rules that the doctor will use to decide what E&M level to submit as a claim to your health insurance, your carrier. They'll use these very same rules. So if you go there, if you have diabetes or rheumatoid arthritis, that they're probably, and you're on medication for them, you will probably be a level 4 all the time, because you're still working on your treatment goal, because you're not going to, you may have waxing and waning symptoms from rheumatoid arthritis. Well, the same thing is true for depression or bipolar disorder. We all know that working towards a treatment goal doesn't mean you're at the treatment goal. And with this, a 99214. So in my perception, and what I know about clinics representing them, is that the vast majority of patients seen by psychiatrists for medication checks, visits, and renewals are going to be a 99214. Not all. The rest are going to be a 99213. And occasionally you'll have a 99215. You'll never have a 99212 which is actually gone, essentially. They've dropped that code. But so no one should be billing less than a 3, it seems to me, and 4s typically, and then 5 occasionally. I just want to get that out. Okay.
Okay, great. I just want to mention before I talk a little bit about how you might document some of these changes, and let me just go back to the previous slide, that 90792 and 90791, which is the non-medical psychiatric diagnostic evaluation code, 90791 and 90792, those are of course still available. Nothing has changed with respect to that code. So when you have a new patient coming in for a consultation, you do have options. You can use a 90792, a 99204. Let me jump 99204, based on time, a 99205 based on time. 90792 does not have a time component. That code is not timed. So the choice is yours. It may depend on a variety of factors, perhaps maximizing reimbursement or the time allocated for that service. Okay, so now let's talk a little bit about documentation. So these are some examples that we have put together, a documentation template that we suggest that covers all the bases. That requires all the minimum information required to be documented for these codes. Now, so this is our change in history, just to show you how the focus of documentation has changed. In 2020, this was the language that we used, where in order to meet either a problem-focused history or an expanded problem-focused history, these terms are probably familiar to you, that you would document a certain number of elements of the interval history. How has the patient been doing since you saw them last? How many elements? So now
And you would also add in a review of systems, excuse me. And now you only need to document the interval history, HPI, history of the present illness, as is clinically relevant. So we've given you some elements to think about, but really it's up to you what you think is relevant and appropriate to document on that day. You still need to document something, but you're not checking boxes. You're not checking, you're not making sure you hit a certain number. Okay. Same thing.
Okay. Yeah, I'm just going to say is the key here is we continue the elements in our template as a guide as to what you might want to target, right? But your decision as to what to target is entirely a clinical judgment. Previously, there were a minimum number that you had to target in order to qualify for each level, and they went up, right? That's gone now, completely gone. Rachel, you can go.
Okay, so and again, this is an example of what a chart might look like with respect to the psychiatric exam in 2020. You needed a minimum elements for a 992114. You needed 6 elements of the psychiatric exam. I'm having trouble reading it, but I think that was for level 3. Sorry, for level 4, you needed 9, and you were literally counting them. Now you have the same elements of the exam, but you're going to, perform them based on what you think should be the focus of your clinical attention that day. And we still have all the elements, and there's of course blank lines, and whatever template your facility is using, you should have a space to fill in any relevant information or within normal limits. Okay, so that's just what the change might look like. Now, for example, when you're documenting based on medical decision making, this is some sample language that we've put together that could be included in a template. So the top half of the chart is 99213, low medical decision making. And we sort of, culled it down to just sort of sound bites and check boxes. Of course, the rest of the medical record will substantiate the checks here. Whether it's in the history, in the exam, in medication changes, all that will all explain the illness that you're treating. But here, you're just checking off one stable chronic illness greater than 1 year, plus continued treatment. You see there's the ampersand over on the right-hand side. Or you might have an acute uncomplicated illness, like, the person who's on their couch for a couple of weeks because they had a bad breakup. So that's the option, but always with continued treatment to, to address the issue. Now, on the other side, on the bottom part, moderate medical decision-making, and 99214 is much more complicated, right? And we have 2 options. Again, we have that chronic illness, but it's not stable. There's exacerbation, and we have provided a variety of checkboxes, and they don't all need to be checked. You just need at least one, but you can check as many as are appropriate. Patient not at treatment goal, acutely worsening, symptoms are poorly controlled, it's side effects. Those are all the language, from the definitions that we wanted to highlight here. Now, again, you'll see the ampersand and prescription drug management. That's the key. You're not going to hit a level 4 unless you have that moderate risk. And one way to demonstrate moderate risk is by treating the patient with prescription drug management. Okay, now the other option for the level 4 is 2 stable chronic illnesses. So you're not having specific exacerbation, but you're treating 2 stable chronic illnesses that are both the focus of the psychiatric treatment, and again, prescription drug management.
Yes, so just to put a underline here, for level 4, if you don't have prescription drug management, essentially you never have a level 4. And since the people we're talking to are going to see the psychiatrist or the NPP for prescription drug management, it seems to me that ends that discussion. And then the other thing that Rachel said is, that the 1 year is not 1 year from that date forward. It's 1 year in both directions. I want to make clear that. In other words, it's 1 year past and 1 year forward is a common. In other words, past time plus forward time is at least a year. So if they've had this condition for more than a year before that date of service, you're fine. If they've had it only for 6 months, but you project that it's going to continue typically for another 6 months, then you're okay too. So it's a combination of looking backwards and forwards that 1 year. It's not that. And the other thing I want to reinforce that Rachel said is that these are conclusions. These are conclusions. The underlying clinical data in the history exam and the medication part of the chart has to still be there that substantiate this. So if you say that the patient is acutely worsening, you have something in your interval history or your mental status that confirms that. If you say that you're addressing side effects, you have something in your note that says that. In other words, these are the conclusions from the note, not the thing itself. I want to make that crystal clear. These are conclusions that you're drawing from the note. Theoretically, and I don't want anybody to think I mean this, but theoretically, you don't need these. You can just have the raw material in the note. And then if someone questions you about it, you can say as well, you can note over there I said this and over here I said that. And when you put that all together, you get a 99214. We don't recommend that. We recommend telling a reviewer or an auditor that this is a 99214 because of this. And then if they need an explanation, well, okay, there's that and there's that on that one sheet of paper. That's our approach. We like to have a record that communicates that the person filling it out knew what the rules were and that the note actually highlights the documentation requirements with headings that communicate that to somebody. So it's not a guessing game. It's not hide and seek to find the information. It's right there, right in front of them with the explanation. Yes, this is a 99214 because I have a chronic illness, at least a year, patient not at treatment goal, patient's on medication, boom, that's a 99214. But it says that in the note. Now, that's the whole point of this, is to give you audit security and audit confidence. All right.
Okay. Okay, so again, this is just an example of how time might be selected. Obviously there are other requirements under Medicaid billing, but if you're just focused on time, you would just check off the amount of total time spent that day. And again, if there is no other additional services, you're just talking about face-to-face time. Don't let the total time throw you. It's, it may or may not be applicable.
But however, as a guide, if you're billing a 99214, you're going to bill it, I think, under MDM all the time. All the time. I mean, that's my practical answer here. We're giving you the info. It may be on the initial visit, you may consider an alternative, but remember, you can still bill a 99214 on MDM, and there's no time associated with it. That's the initial visit. But here are the usually initial visits under Medicaid rules, under OMH rules, have a time associated with them, so that that may intrude, so to speak. But on the established patients, in my view, no one should be using time if you're doing a 15-minute interval, because you won't even get to a level 3 with 15 minutes on time, but you will get to a level 4 on 15 minutes if you're doing code selection based on medical decision making. And that's the nuance point there. Okay.
Okay, so this is a chart that we put together to focus on some of the changes in Medicare fees. Now, and this is just an example to show you how reimbursement from Medicare and third-party payers may be significantly increased under this new framework. So these are some of the common codes that physicians and other prescribers may use. In the first two columns, you can see how from 2020 to 2021, all of the RVUs were increased. Now, the RVU is the relative value unit that the AMA assigns to each CPT code in the book. It establishes the work value associated with that code. And they're then multiplied by a conversion factor, a geographic locality factor, and that's how they come up with the Medicare fees. So all of the RVUs went up. And that's why we're seeing a significant, with the change in the 99214, particularly, that's why we're seeing a great increase in potential reimbursement for the 99214, particularly in Medicare and with the private payers. So if you look at the orange arrows that I put in there, you can see that, for example, in 2020, the 99212, and this is just an example, this is a participating fee, a Medicare participating fee for locality 1, which is Manhattan. In 2020, the level 2 was $53.81. The 99213 was $87.76, just by itself. Now, in 2021, if the patient qualifies for a level 4, that fee has now gone up to $142.88. So that, truly demonstrates the possibilities for increased reimbursement for facilities with respect to payers other than the Medicaid system.
This is the power of the change. No matter, and it seems to me, is whatever the duration of your face-to-face time for your medication visit, right? If you were billing a 2 or a 3 for that to Medicare for that service, and you were probably billing a 3 even at a half-hour interval because of the probably, and not billing a 4, you can see all the money that's been placed on the table here. And this is pure Medicare dollars that will flow to your clinic for those 4s. So as I said, there's a significant amount of money available here for the duals and Medicare, Medicaids, and for anyone who has third-party insurance. Many of them use the Medicare fee schedule as a proxy or, as a percentage of Medicare. So that's where you have to keep your eye out. But even for the about a third, I think, of duals with Medicare, Medicaid, you're going to significantly bump up your reimbursement from Medicare. Even if you were billing a 3 and now going to a 4, you can see is that you're picking up 42 plus 13 is $53 from a 3 to a 4. I mean, that's quite a 60% increase in reimbursement from moving us from a 3 to a 4. From a 2 to a 4, it's even you can see the numbers. It's even greater. So that's our focus here. So and you can calculate the impact yourselves by simply looking at your historic billing to third-party payers in Medicare and do the math. You can do the math yourself and figure out how much additional reimbursement you will bring down through this simple change, relatively simple change. All right.
Okay, great. And then the last, 1 second. Okay, I think this is our final slide. We just wanted to show you an example of the documentation template that we've put together. And this one obviously is just really a sample. It really wouldn't work because we've included all the different elements, whether you're selecting the code based on MDM or time. And let me just go through from the top. So we have the section on interval history, which is similar to what I already showed you. Again, the psychiatric exam, both of those are, just a clinical focus. Then we have, a section on current or updated diagnoses, any changes in medication, and we always have our box about no side effects or adverse reactions noted or reported. I'm sure your EMR has it as well, but that's extremely important. And then a section on iStop, if applicable, if the patient is receiving a 2, 3, or 4 schedule drug, a section on lab tests. And then we have added in our template a medical necessity component, which we believe is very helpful with respect to any audit of the record. It's a treatment plan update as well. And so really you're talking about, why is the patient coming in at that frequency? And the patient needs the continued frequency of, 1 or 2 or 3 times a week, whatever it is, or once a month, because this treatment is reducing their symptoms, either improving their functioning, for medication stabilization, et cetera. So we think that language is very key, and that's also helpful to further explain the treatment.
So then we have the section on, so I have code selection based on medical decision making. And I just put that in as a heading just for this purpose for the training, just so you can see what we're focusing on. And then we have, you know, if you were at a level 3, what your check boxes would be. If you think the patient qualifies for level 4, what your check boxes would be. And then the other option is if you're selecting that code based on time, again, you would select the appropriate time for total time, face-to-face plus any other services. And we've also added, you know, because of the pandemic, because virtual visits have become so commonplace, we've added a checkbox for in-office or virtual. So that's just an example of what a template might look like and how incorporating some of this new language in the EMR might look. And I think that is our final slide. And this is our contact information. And I know that Brianna has some additional slides she wants to share with you. So I think we'll stop there and hopefully we can have some time for a few questions.
Yeah, yes, thank you, Rachel and Seth. So this is Boris, and I'm, you know, going to be moderating the Q&A with Brianna. And again, just to let folks know, please continue chatting in your questions. We actually got quite a few questions, so thank you for that. We'll try to get to as many as possible today. And again, we will be posting both the recording and the slides on our website, and we also have our contact information as well. So we'll jump right into the questions, but one of the things I just want to again underscore, and I know both Rachel and Seth has said this, you know, the Medicaid rates and the Medicaid rules for OMH have not changed because of this. There were a couple of questions around that. This is again focusing on Medicare and third-party commercial payers, so I just want to underscore. And as both Seth and Rachel has mentioned throughout the presentation, you do need to still be mindful of the rules from all the payers and making sure you meet all of that. So jumping into some of the questions that we have received. So one question we got was, what is the correct procedure of coding if you have 3 elements, but they're all at different levels? So like moderate, straightforward, and high. Like for example, a stable patient on clozapine. So any suggestions or recommendations there?
It's a little tricky. Again, a truly stable patient on clozapine probably is a level 3, because you have no exacerbation. But again, there can be side effect issues if they're having side effect issues. So it's a bit of the real question is, to my mind, is, and Rachel focused in on this, is what do we mean? Where is the patient in the course of their treatment? In other words, I guess it's possible, from my experience, you know, in dealing with this with the Psychiatric Association, for a patient to be on clozapine, Clozaril, and doing very well, and just coming in for renewals, and that's it. And that probably gets you to at least a 3. But if they, more typically, I guess, in my sense, if they're still working towards a treatment goal in terms of functioning or symptomatology, then you got a 4. So to me, it's situational, and that's what CPT and Medicare wanted. They wanted it to be situational. It could be that a person like that would be a 3 for a while. Then, as we all know, what happens is there's an interval. There's something happens in their life, a stressor, and symptoms reoccur, and therefore they may go back to a 4. And it's dynamic. That's the sense. It's dynamic, and that's what they wanted. They didn't want code selection to be based on simple writing down irrelevant information on elements that have nothing to do with clinical judgment. So that's my best answer. You tell me how the patient's doing, and I'll tell you whether it's a 3 or a 4. That's the best answer I can give you.
All right, thank you. So there we have a number of questions about time, and especially if time by a non-prescriber psychiatrist or nurse practitioner count towards time. especially around, you talked about getting prior authorization counts.
Again, I think the simple answer is yes. If a nurse is involved with the pharmacy, if a nurse is doing it on the other staff, it's a little uncertain what they mean about does other staff. We don't have clear. I think, Rachel, we don't have clear indication. I think it's not a clerk or a secretary. I think it has to be someone, but it doesn't have to be an MD to make that inquiry. But keep in mind that you want to make sure that pursuing time is worthwhile. In other words, if you got a 4 without time, then why would you bother worrying about that? Now you might get to a 5 using time because you had to speak to the another physician, let's say an internist, it has to be on the same day, and you had to speak to the pharmacy benefit manager, and you had to then talk to the let's say if it was a child, the child's school, the teacher. In other words, and there was a lot, and then time. Then you may get to 60 minutes and you might have the level 5. But if you have a level 4 on MDM, you're probably doing pretty well reimbursement wise.
Okay. I have something to add. There is a concept called a shared or split visit, where a physician and another healthcare professional are jointly providing the face-to-face and or non-face-to-face services related to the visit. So you can combine, say, the nurse practitioner plus MD. That's possible.
Okay, and so I think, Seth, you kind of answered it, because we did have a question about, can you define other qualified professional? It sounds like that still needs to be clarified, actually, right?
But I think, again, to me, there's a simple, I'm just trying to make it simple for everybody. Right. Given, I want to make it as simple as possible. If you get a level 4 on MDM, you're pretty good,
Right.
Pretty good. And it seems to me yes, you might leave a few bucks on the table because you had a lot of time, but then do you really want to bother counting up all that time, right? And documenting that time. Sometimes it's difficult to do that. So from a practical consideration, you get to a 4 on MDM, I think you should feel pretty good. At that point.
Got it. Thank you. I know we got a couple of questions about folks are not able to find these codes in the OMH rate schedule. It is there. You have to look for them. They're highlighted in one of the Excel tabs. It does refer to it. So I just would invite folks to mention, there's a range that actually mentioned in the OMH website. But again, just also make sure you're following all of those components that's required by Medicaid and OMH. So let me just look through some of the other questions that we got. Also, Brianna, please feel free to jump in here.
If that's okay, I actually saw a question that I thought would be helpful to address. So these changes are established by the American Medical Association and the CPT book. So they apply to all treatment by physicians and other professionals that use E&Ms. They apply across all payers, Medicare, Medicaid, third party, and even treatment that is entirely, paid privately. Whether the Medicaid fees will be impacted by that, we've all said that's not the case. But again, the focus of documentation and code selection applies across all payers.
Got it. Thank you. We do actually back to, and I know, Seth, you're emphasizing the MDM part, but realizing there's time is also a component. So I guess one of the questions was, if for whatever the reason, a prescriber met with an individual and actually did not prescribe medication, could time then be used as a way to bill for this, as long as it, of course, meets the duration criteria and so forth?
I would say, well, again, this is fact dependent. If, for example, this patient had been on medication and you're doing a washout on medication, then I think you're still under medication management, right? So that's all right. The answer is situational. Why didn't you renew the meds on that day? Does it mean that, explain it to me. because if it's in the context of prescription drug management, then okay, right? But if it's then if you're never going to renew the meds and the patient is never going to be back on meds, tell me, why is this patient seeing the psychiatrist, right? In the
Right.
clinic setting. So that's
Yeah.
my answer.
All right, but technically, if that session occurs, I guess at the end of the day, can somebody bill for that session?
No, I'm saying to
Time
you,
now. Okay.
if the context is that, yes, the patient is going to be on medication, but today I didn't write a script today because for whatever reason, for example, the patient's on benzodiazepine, okay? And the patient's on a given dose, but it's more of a PRN situation. So that the patient comes in a month later and says, I still have most of my medication left. At the rate I'm taking it, I don't need a renewal. So the doctor doesn't write a renewal. Well, that's still a level 4 if they otherwise meet it, of course.
Got it.
Because that's my point. And
Okay.
that would be I think, a typical scenario with a benzo, where the patient says, I'm doing better now. I'm not taking it. I'm doing a PRN when I get an anxiety attack, and I have plenty of meds. I don't need any more. And the doctor is happy to hear that. The doctor doesn't want to load them up with extra benzodiazepines, right? If they don't need it, right? But that's still medication management. That's the point. Because you've documented in the note, that's why you didn't write a script today. Patient still has adequate medication. That's the whole point of this exercise, all right?
Yep, got it. Thank you. Just being mindful of time. Also, Rachel or Seth, I don't know if you've seen any question.
We can go a little longer.
Yeah,
It's okay.
yeah.
It's
Usually,
up to you guys. We'll stay a little longer if you want us.
I appreciate that. Usually our participants sometimes have a hard time with this, with the scheduling, but so maybe we have one more question that we can address. So I'm just looking through some of the questions that we might have not touched on. And so again, I think we're still having a lot of questions about time versus MDM, and clearly the clinics can use either one. There's clearly a benefit to using MDM in a lot of instances, but it's not like you have to choose one or the other. It's situational, right? So one visit could be MDM. Next time you see the same client, it could be time, and another psychiatrist or nurse practitioner could be doing MDM or time. There's no as long as, of course, you always have to pick the appropriate rules.
Exactly right. Exactly right, Boris. Exactly right.
Okay, I appreciate that. I think, again, knowing that we're basically at time, I just want to remind folks again that we have recorded this, and that both slides and the recording will be available. I want to say thank you to Rachel and Seth for this great presentation. This was really helpful. So I really appreciate that. And again, thank you for joining us, and have a great rest of the day. Thank you, everybody. Take care.
Thank you.
Thank you.
Take care.
Bye.